there's going to be there's going to be a few scenarios and questions that you can answer, so that way it's a bit more interactive. And feel free, if you have any questions, please message them in the chat and I'll try and answer them. So skin cancer is an overall topic. It's the seventh most common cancer it's the seventh most common cause of cancer in the UK, and it can be divided into benign tumors, premalignant lesions, and malignant tumors. So we're going to start off with benign tumors, and there's four main types that we can talk about, which is melanocytic nevi, dermatofibroma, seborrheic keratosis, and epidermoid cyst. So we have a scenario here. A 60-year-old woman is worried about a lesion on her neck and is worried because her sister previously had skin cancer. She first noticed it last week and it hasn't changed in color, shape, or size. In the middle of her back is a 5mm pigmented, circular, elevated nodule. It has a smooth border and is brown throughout. Which of the following is the most likely diagnosis? So there should be a poll going on about now. So if it's A, B, C, or D.
Just a reminder, the polls are anonymous, so don't be afraid, just give it a go.
I'll give it another few seconds. Okay, so yeah, most of you guys have got it right. It was B. So I'm going to go over why it was compound instead of junctional and intradermal in my next slide, but I'll briefly touch on why it's not malignant melanoma. So the reason why it isn't is because it doesn't really go in line with the diagnostic features of malignancy. So for instance, it's 5mm, so it's less than 6mm in size. It's circular, which means it's actually symmetrical. And it's brown throughout, which shows that it's homogeneous in color, so it leans more towards benign. And the fact that she noticed it last week and it hasn't really changed in color, shape, or size, so that means it wouldn't really be malignant. So junctional, compound, and intradermal are all part of acquired melanocytic nevi. And basically, it's presented in childhood or young adults. And nevi itself is a proliferation of melanocytes, which are the pigment cells, and they form small collections, which are called nests, basically moles. So it normally starts off as a flat pigmented nevi, which is called junctional nevus. And this is because the melanocytes are in the epidermis, as you can see in the picture above. The color can be heterogeneous, and you most commonly see this on the palms, soles, or the mucous membranes. Next, the melanocytes can migrate downwards into the dermis, and it can form like a dome-shaped elevated nevi, and it's normally uniform in color and it's quite smooth. So that's called compound nevus. So if we quickly look at the question before, it's got the same characteristics as compound. So it was elevated, smooth border, and brown throughout. So that's why it's compound. Next, the melanocytes will be in the dermis and the epidermal component is lost. So that means it will change into a light brown or flesh-colored papule called intradermal. Other types of melanocytic nevi are congenital, and this presents normally during birth or the neonatal period, and it's normally more than 1 centimeter in diameter. Spitz is normally pink or red in color, and it develops over a few months in children, and it's normally seen on the face and legs. And halo, which is normally common in adolescents. However, if you see in adults which are more like around 40 to 50 years old, it may indicate melanoma somewhere else. So that means you'd have to check for the skin, eyes, and mucosal surfaces. So here we have another scenario. A 70-year-old lady presents with a number of skin lesions she describes as unsightly. On examination, she has a number of raised lesions with a greasy surface located over her trunk. The lesions also have scattered keratin plugs located within them. What is the diagnosis? A, B, or C? give it another maybe 20 seconds. Okay, great. Yeah, so majority of you guys have got it right. So it's B, seborrheic keratosis. And the reason for this is because, as you can see, there's a greasy surface, which is very characteristic for this. And it's located on the trunk, which is one of the most common sites, aside from the face. And you can see keratin plugs. So it's in the name, keratosis, keratin plugs. And as you can see here, there's loads of different plugs around the lesion. So more about it is that it's most commonly seen in 50-year-olds. The etiology is idiopathic, and it's normally multiple lesions over the face and the trunk. Subtypes are recognized, such as flat, raised, filiform, and pedunculed, and it has a stuck-on appearance. So that means that the lesion kind of looks like as if you can peel it off, like a sticker. The colors can vary, and again, the surface has a greasy scale over it. So basically, the main points here is face in the trunk, stuck-on appearance, greasy scale, and keratin plugs. The management is normally you can leave it alone, or you can do a simple shave excision. Another scenario is a 20-year-old lady presents with a nodule on the posterior aspect of her right calf. It has been present at the site for the past 6 months and occurred at the site of a previous insect bite. Although the nodule appears small, on palpation, it appears to be nearly twice the size it appears on examination. The overlying skin is fairly pigmented. What is the diagnosis? There should be a poll coming up. Is it A, dermatofibroma, B, seborrheic keratosis, or C, epidermoid cyst? Feel free to always answer the polls because it is anonymous. Okay, I'll give it a few more seconds. And okay, yeah, okay. All right, so the answer was A, dermatofibroma. And the reason is because it normally occurs in young adults, so the 20-year-old lady. The most common site is the lower limbs. And the nodule normally occurs after skin injuries. The previous insect bite would be in line with this. Another characteristic for dermatofibroma is the fact that the nodule might appear small, but then on palpation, when you actually visually feel it, then it will be larger than what it looks like. So a bit more about dermatofibroma. It's an abnormal growth of dermal dendritic histiocyte cells. Again, like we said, it's after an injury. And again, like we said, it's on the extremities of young adults. The lesions feel larger than they visually appear. And it's normally solitary, firm, elevated nodules. And what's more characteristic about this disease is the pinch test. So if you pinch the lesion, then you'll see like a dimple forming. Normally, it doesn't require any treatment. However, if it's symptomatic, so for instance, the patient feels like it's tender or irritated, or they just want to get rid of it because of cosmetic purposes, then you can surgically remove it. The last one is epidermoid cyst. And it occurs because there's a blockage in the hair follicle and it's filled with keratin and debris. The clinical features is that it affects the face and the trunk, and the dark shaped opening that you can see in the picture is a central punctum, and it can contain small amounts of sebum. Normally, you don't need to treat it if it's uncomplicated cases, or if you can, if you'd want, then you can remove it by surgical procedures. Okay, so before we move on to pre-malignant lesions, if there's any questions about the benign tumors, feel free to put it in the chat. If not, then I'll move on to the next topic. Okay, great. So premalignant lesions, there's three main types that we're going to go through: actinic keratosis, Bowen's disease, and lentigo maligna. So actinic keratosis is a common premalignant skin lesion that develops from chronic sun exposure. So that's why it's sometimes related, not related, sorry. It's normally referred to as solar keratosis. And what happens is that the ultraviolet light will normally damage the DNA of keratinocytes, and this can cause abnormal proliferation. And then over time, if it's left untreated, it can become cancerous. So I have another question: if left untreated, which type of carcinoma can it develop into? Squamous cell carcinoma or basal cell carcinoma? Okay, yeah, the majority of you guys got it right. It is A, squamous cell carcinoma. So basically it has a 10% chance of turning into squamous cell carcinoma over 10 years. And the risk factors is if a person normally sunburns quite easily, if they're fair-skinned, blue eyes, or they have freckles, if they have a weakened immune system. So for instance, if a person has got AIDS or leukemia, or they're taking organ transplant medications. Other risk factors are increasing age or those with HPV infection. So the clinical features is that it's normally found on sun-exposed skin. So the most common sites is either like the scalp, lips, neck, or the back of the hand. Features is that you can see yellow, white, scaly crusts, and normally people refer it to as like sandpaper-like patches, as you can see here. And it can vary in color from pink, red, brown, or the same color as the skin. And multiple lesions can be present. The diagnosis is normally clinical and with biopsy. And the topical treatment is first line 5-fluorouracil. Other alternatives can be diclofenac gel or topical imipramide. Other alternative treatment can be cryotherapy, as it's effective for 75% of the lesions, and photodynamic therapy. So that's basically when the chemical solution is placed onto the skin, and that makes it quite sensitive to light. And then artificial light therapy is exposed on the affected area, so that way it will damage the destroyed cells. And this is particularly useful in sites of in anatomical sites where there's poor healing areas. So for instance, the lower leg. Another treatment can also be surgical excision if it is unresponsive to treatment. So next up is Bowen's disease, and this is a precursor to squamous cell like the previous one, and it's more common in elderly. So the etiology is UV exposure, the use of tanning beds, immunosuppression, occupational disease such as exposure to arsenic, and those with HPV infections. The features is that it's normally quite slow growing, it's exposed on sun, and it occurs on sun exposed areas, and it's very well defined with a red scaly plaque and a flat edge, as you can see in the picture on the right. The treatment, again, you can do biopsy as well. Topical treatment is 5-fluorouracil, which is the same as actinic keratosis. However, for Bowen's disease, you have to use it twice daily, and it's for a longer period, so 4 weeks. Whereas in actinic keratosis, you could use it for 2 to 3 weeks. The alternative treatment is again the same as the previous one. So you can do cryotherapy, photodynamic, and surgical excision. And also just to note that 5-fluorouracil can cause inflammation or erythema, so you can give topical steroids if those are the side effects. The next up is lentigo maligna. And lentigo maligna is a proliferation of the pigment cells, which is melanocytes, across the basal layer of the epidermis. So again, it's a precursor to lentigo maligna melanoma. The etiology is exposure to the UV light. So basically, the solar damage causes an immune tolerance, and this can lead to abnormal cells being unchecked. Again, so it's found on sun-exposed skin, particularly on the nose and the cheeks. And what you can see here is a dark pigmented macule, irregular borders, and a smooth surface. You can also see the color irregularities within the lesion. So it kind of looks like an island, and it varies in size, as well as it can grow quite gradually. And it's most commonly seen in 60 to 80-year-olds. So clinical diagnosis is again excision biopsy, and you normally do that with 2 to 3 millimeters of margin. And you normally do surgical excision with a safety margin because it has such a high risk of recurrence. Alternative treatment can be chirotherapy, radiotherapy, and imiquimod cream. However, these alternative options do not have a high cure rate as the standard treatment, which is surgical removal. Okay, so next we're going to go into malignant tumors. And it's basically classified as non-melanoma and melanoma. Within melanoma, you have 4 different types: lentigo-malignant melanoma, acrolentiginous, superficial spreading, and nodular. Within non-melanoma, you have basal cell carcinoma, where there's 3 main types we'll talk about today: superficial, nodular, and infiltrative. And then the next is squamous cell carcinoma. So squamous cell carcinoma is the second most common skin cancer, and it is a locally invasive malignant tumor of the epidermal keratinocytes. It's more likely to spread and metastasize compared to basal cell carcinoma. The risk factors is excessive UV exposure. So basically 90% of squamous cell carcinoma is associated with DNA mutations, especially with UVB, so it's very important. Other risk factors is smoking, long-standing ulcers, pre-malignant lesions like the ones we talked about, so actinic keratosis and Bowen's disease, chronic inflammation, genetic predisposition, and immunosuppression. So patients that are following renal transplant or those who have HIV. So the clinical features is that it begins as a small nodule, and it can take on the form of either scaly, nodular, or ulcerated. So over here, as you can see, it becomes, the center is necrotic and it can slough off. Or there's another form which is keratotic, and you can see that it's an ill-defined nodule which can ulcerate and it has some scaly crusts. Other features is that it can be seen on the face, neck, and lower lip, and the onset is over months. So the management. The diagnosis is by biopsy. Surgical excision is normally the treatment of choice. So if the lesion is less than 20 millimeters diameter, then you use 4 millimeter of margin. And if it's higher than that, then the margins would be 6 millimeters. Moss micrographic surgery is an alternative, and it's best for ill-defined large recurrent tumors. And this can be used in high-risk patients. So high-risk patients means that small cell carcinoma where it is seen on the ears, lips, or the scalp, or if the tumor size is 2 centimeters larger, if it's a high grade and growing quite quickly, or if the person has got a weak immune system, or that the cancer has grown in or around the nerves. So that would classify as a high-risk group. Another surgical treatment can also be chirotherapy, which is for small, thin, low-risk tumors. Alternative treatment is radiotherapy for large non-resectable tumors, and chemotherapy if it's metastatic. So next up is basal cell carcinoma, and it is characterized by slow growth, which is the opposite of squamous cell, and local invasion. Now this one is the most common malignant skin tumor, rarely metastasizes. And the cause is multifactorial, so there's loads of risk factors. So for instance, chronic UV exposure, males have a higher risk, history of severe sunburns in childhood, the skin type 1, so that means that they always burn but never tan. It increases with age, inherited syndromes like Gorlin syndromes. This is basically an autosomal condition in which there's a mutation in the tumor suppressor genes. So this causes abnormal proliferation of cells, and this can increase the risk of cancer. Other risk factors is previous history of skin cancer, as well as immunosuppression. So we have another question here. What is the most common type of basal cell carcinoma? Nodular, superficial, or sclerosing? I'll give it around 10 more seconds. Okay, great. Yeah, most of you guys got it right. It is nodular. So yeah, so this basically accounts for 60% of basal cell carcinomas. And the characteristics is that it is a shiny or pearly papule or nodule, as you can see in the pictures above. You can see visible blood vessels on the picture on the left. It can look quite waxy and glossy with a slightly depressed center, or it can become necrotic or an ulcerated center. And it is most commonly on the head and the neck. Now, basal cell carcinoma in skin of color is actually quite difficult to diagnose because of its severity and the pigmentation. So in these cases, you'd normally see the nodule being brown or black, which is what you see in pictures on the right-hand side. So next is which type of basal cell carcinoma is considered as the most aggressive? A, nodular, B, sclerosing, or C, superficial? I'll give it 5 more seconds. Yeah, the majority of you guys got it right. It's sclerosing. So sclerosing, even though it's the most aggressive, it is quite rare. And it's found in the mid-facial sites. So it's normally seen as a waxy scar-like plaque with distinct borders, and it can infiltrate the cutaneous nerves. The other type of basal cell carcinoma is superficial, and it's normally seen in younger adults. And the most common sites is the upper trunk and the shoulders. It's seen as a slightly scaly, irregular plaque with multiple micro erosions, and it can be misdiagnosed as eczema and psoriasis. So basal cell carcinoma management, diagnosis is again the same, diagnostic biopsy. The excision is the treatment of choice, and where the margins are normally 3 to 5 millimeters. And Moss micrographic surgery is normally used for high-risk recurrent tumors. Now, high-risk tumors in this case is when the cancer is either on the eyelids, nose, ears, or it's around the eyes. Again, like squamous cell, if it's larger than 2 centimeters, or if the edge of the carcinoma is uneven, or if the cancer has grown in or around the nerves. There's also quite high cure rates with most micrographic surgery. Other surgical treatment can be chirotherapy as well as curettage. Other treatment options can be radiotherapy when surgery is not appropriate, topical photodynamic therapy when there's low risk, small superficial basal cell carcinoma, or topical treatment for small and low risk lesions. So the prognosis, basically death is quite rare, and if it's detected early, then there's prevention of extensive treatment. But basal cell carcinoma, like we said before, if it can cause local spread, but it rarely has distant metastasis compared to squamous cell carcinoma, where it tends to grow a bit more faster. And squamous cell carcinoma, the prognosis is based on whether the tumors are differentiated, the diameter, how deep it is, the thickness, as well as if the patient has a weak immune system. So now we're going to move on to the last bit for malignant tumors, which is melanoma. So there's 4 types: lentigo-malignant melanoma, acrolentiginous, superficial spreading, and nodular. So malignant melanoma is basically, it causes 75% of deaths associated with skin cancer. And this is because it is quite deadly because it metastasizes very, very quickly. And this is the proliferation of the melanocytes, which is seen in the basal layer of the epidermis. So as we've said, as we've said this before, the risk factors is UV exposure, the history of tanning beds, history of multiple or atypical moles, if your skin type is 1 or 2, or if you have lightly colored hair, so for instance, or red hair, blonde hair, or even lightly colored eyes. It also increases with age, if there's personal or family history of melanoma, immunosuppression, and history of sunburns. Now, just a way to remember a few bits of the risk factors is sun in the sun. So F means for fair skin, U is UV rays, and N is numerous nevi. And bands is a mnemonic just to remember the anatomical sites where it can cause higher risk of metastasis. So B for back, A for arms, and N for neck, and S for scalp. Now, for malignant melanoma, there are 2 different ways it can grow. So there's radial growth, where you'd see it, where it's basically confined to the epidermis. And then there's vertical growth, where it will invade the dermis, and it will show an outward projection. So we're coming on to the ABCDE rule, which is what you'd use for symptoms as well as diagnosis. So if the lesion is asymmetrical, or if B is for border, so if it's irregular, scalloped, or poorly defined border. C is for color, so that means if it varies in color and it has different shades. D is for diameter, so basically melanomas greater than 6 millimeters is raised for suspicion, as well as E is for evolving. So if it is changing in size, shape, or color, or if it looks different than the rest of the moles. Oh, no, not the moles, just looks different from the rest of the lesions. And there's a criteria. So there's a major and minor criteria. Major criteria accounts for 2 points each. So that includes the change in the size, shape, and color. And the minor criteria indicates 1 point each. So if the diameter is equal to or more than 7 millimeters, if there's inflammation, oozing or bleeding, or altered sensation. And the suspicion of malignant melanoma is if it's equal or more than 3 points. So we have another question here. What is the most common type of melanoma? A, lentigo malignant melanoma, B, superficial spreading, C, acral lentiginous, or D, nodular. I think I'll give it 10 more seconds. Okay, so I think we're kind of divided on A or B, but it is B, so it's superficial spreading. So this normally accounts for 70% of cases, and if it's detected early, it has a very good prognosis, and it normally occurs in either sun-exposed or non-exposed skin. So as you can see here, it's quite common in lower limbs, the back and the chest in young and middle-aged adults. It initially grows on the radial plane. So like we said before, that means that it's confined to the epidermis. And then when the lesion remains thin, it can be followed by a vertical invasion. So what we said was that it invades the dermis and has an outward projection. So another question, which type of melanoma is the most aggressive? A, nodular, B, acral lentiginous, or C, lentigo malignant melanoma? Give it a few more seconds. Okay, yeah, the majority got it right. So it's A, which is nodular. And this normally accounts for 15% of cases, and it's normally quite advanced at the time of diagnosis. So it is the second most common. It's found in around the trunk area in young adults. And this one has a red or black lump, and it can bleed or ooze. It has no radial growth, and the lesions normally grow quite rapidly. And even though it's red or black lump, around 5% of cases can be seen as amelanocytic. Okay, next we have lentigo maligna melanoma, and it's the less common type. It's seen in the face and neck in elderly patients, and it's a growing mole with the diagnostic melanoma features, the ones we talked about before, which was A, B, C, D, and E. Now, all of these three types are related with UV exposure, whereas the last one, acrolentiginous, doesn't really have much of a relation to UV exposure as one of their risk factors or causes. So this one's quite rare. It's seen in the palms, soles, and the nail beds in elderly patients. It's more common in African Americans and Asians, and you can see a subungual pigmentation, which is seen on the bottom right picture. That's basically where you see like a black line on your nail beds or on the palms or feet. And normally it can be a smooth surface at first, but then it can form to be an irregular surface that could be dry or warty. So those are the four types of melanoma. Okay, so the diagnosis is by dermoscopy, and you have to do a full thickness excisional biopsy with 1 to 2 millimeters of margin. Now, the management, because it metastasizes rapidly and it's quite deadly, this one you have to do an urgent 2-week referral. And then once the diagnosis is confirmed, then you might have to determine whether re-excision is needed. If it is, then you can do a wide lesion excision, which means that you remove the biopsy scar with margins of excision, and this is determined by Breslow thickness. So here on the table is Breslow thickness. So if the lesion is under 1 millimeter thick, then the margins would be 1 centimeters. If the lesion is 1 to 2 millimeters, then it'll be 1 to 2 centimeters, and so on. Now, if you can do other investigations such as sentinel lymph node biopsy or imaging such as CT, for high risk tumor, for high risk cancer, and if sentinel lymph node biopsy is positive, you might have to do a complete lymph node dissection. Other treatment can also be adjuvant radiotherapy, as it helps to improve the control in those of risk at local recurrence. So that is when the lesions are normally more than 4 millimeters, or if they're ulcerating. For metastatic disease, there is basically no cure. So you can do palliative treatments such as radiotherapy, chemotherapy, immunotherapy, and systemic. So we have another question. A 55-year-old female was diagnosed with a melanoma on her back, and it has been excised surgically. There's no evidence of spread or lymph node involvement. What is the most important factor to predict the recurrence? A, Ann Arbor, staging, B, diameter, C, pigmentation level, or D, Breslow's thickness. I'll give it maybe a few more seconds.
Just as they're answering this question in the chat box, I'm not sure if you can see it.
Oh no, I can't see it.
Okay, someone's asked, how common is it for superficial spreading melanomas to start from a mole the patient has had for a long time?
I'm not too sure about them. I'm not too sure about the question, but I do feel like because superficial spreading is the most common, because it's 70% of basal cell carcinomas, I can't really say. I'd have to maybe research and then let you know. But normally the mole, it will kind of be a precursor for lentigo maligna melanoma, because that one is when you see the mole features kind of changing, if that helps.
At the end, if you want to put your email down, then they can send you any questions they have, and you can get back to them.
All right, yeah, sure.
Yeah.
I'll put it in the chat in a bit. So yeah, the majority was right. It was D, Breslow's thickness. Let me So For malignant melanoma, it does depend on the stage of melanoma. So this will include, for instance, the thickness, if it's ulcerated, or if it spreads to the local lymph nodes. Now, the recurrence of melanoma is based on Breslow's thickness, and this is the single most important factor. So as you can see in the table here, less than 0.75 millimeters means that it's quite a low risk. 0.76 to 1.5 means medium risk, as you can see, because it's 80 to 96%. And then above 1.5 millimeters is very high. So that's it for the presentation. We do have 2 more questions. So an 80-year-old male had a round skin colored spot with blood vessels visible and a pearly rolled edge on his nose. What is the most likely diagnosis? A, basal cell carcinoma, B, melanoma, or C, squamous cell carcinoma? I'll give it maybe a few more seconds. It seems like the majority have got it right. Okay, yeah, it is basal cell carcinoma. And this is because you can see the, oh, sorry. Second. Yep, it's basal cell carcinoma because of the fact it has blood vessels visible and a pearly rolled edge. And this is just a visual, if it helps you to remember, that basal cell carcinoma is normally seen on the nose, a pearly papule or nodule with an umbilicated center, and it grows quite slowly. Whereas the squamous cell carcinoma, you're going to see crusting, ulcerations, and it's definitely more aggressive. And the last question for this presentation is, a 20-year-old female had a bleeding black lump on her back and was diagnosed with melanoma. Which type of melanoma is the most likely diagnosis? A, nodular, B, superficial spreading, and C, acral lentiginous. Okay, I'll give it maybe 2 more seconds and then I'll end the poll. But yeah, the majority did get it right. So it's nodular. And as we remembered before, nodular, it was the red-black bump that can bleed or ooze. And regarding to the question that was asked about superficial spreading melanoma, basically a quarter of superficial spreading melanoma can develop from already existing melanocytic nevi. So if